Hello, and welcome to another installment of the Think Thrombosis podcast from medthority.com. My name is Geoffrey Barnes. I'm a cardiologist and vascular medicine specialist at the University of Michigan. And for this podcast focused on real-world evidence of prophylaxis and treatment of cancer-associated thrombosis, I am thrilled to be joined by my good friend and world expert, Dr. Marc Carrier. Marc, welcome to the program.
Thank you, Jeff. You're too kind. It's a great pleasure to be here. I'm Marc Carrier. I'm one of the hematologists at the Ottawa Hospital, a professor of medicine at the University of Ottawa, and I do venous thrombosis in the setting of cancer for a living, both clinically and that's also my focus of clinical research. So it's a great pleasure to be here.
You know, Marc, I want to start us off talking in this podcast about the importance of preventing cancer-associated thrombosis. You know, we've talked in another podcast installment about how common and how morbid and highly the high mortality rate there is with cancer-associated thrombosis. And there's some really good ways that we can risk stratify and even prevent cancer-associated thrombosis. But the guidelines and the randomized trials are one thing. What's actually happening out there in the real world? And I'm wondering if you could give us a little bit of a sense for how often are we giving guideline recommended chemoprophylaxis to at-risk patients who have different cancer types?
You're quite right, Jeff. It's such a difference, or there's such a discrepancy between guidelines recommendation and what actually happens in the real world. And there's no doubt that pharmacological thromboprophylaxis is underused, and surveys of medical oncologists in the United States and elsewhere in the world have shown that minimum amount of patients that are deemed to be at high risk even have a discussion about venous thrombosis. What are the signs and symptoms of DVTs and PEs? And I personally believe that's part of the reason why we see a lot of incidental PEs. So when patients go for a staging CT, they have a diagnosis of PE, and then they're sent to you for discussion about treatment. When you actually talk to the patient, they had signs and symptoms of PE. Most of them were symptomatic. They just didn't know about the underlying risk of clots. So it's, there's not a lot of public awareness or patient awareness. We need to do better with medical oncologist awareness. So we need to work on implementation strategies to go from clinical practice guidelines into clinical practice so that we can prevent morbidity and mortality associated with venous thrombosis.
And just to clarify, when many of us as who are internists or trained in internal medicine and family medicine, when we hear about the term VTE prophylaxis, we think about giving prophylaxis in the hospital setting for a hospitalized patient. But here, we're actually really talking about ambulatory patients who are receiving treatment for their cancer, especially those undergoing chemotherapy. When should we start thinking about risk stratifying and initiating chemoprophylaxis for a patient with cancer?
We should probably think about it at a new diagnosis and then when there's disease relapse or change of chemotherapy. And that's something that can be very easily incorporated, like a chemo teach, for example, having a pamphlet or a discussion about signs and symptoms of DVTs and PEs, and then for patients that may be deemed to be at high risk, having a way through the electronic medical records to stratify these patients so that they can be seen by someone that will have a discussion about the risk and the benefit of thromboprophylaxis and provide some education specifically in high-risk patients.
So, as you mentioned, this is a underutilized strategy to prevent chemoprophylaxis. I'm wondering what examples of maybe systems or groups that have implemented this well are there in the literature that we can cite? Anyone that you can point to, and what is it that they do that seems to make their approach so effective?
Yeah, so there's a couple of interesting models in the literature, one from Vermont in Burlington and one from the Cleveland Clinic, where they use the electronic medical records to identify patients that will be starting chemotherapy that might be at higher risk of having venous thromboembolic complications. These patients then are sent to have a consultation with an hematologist, a pharmacist, or an RN to discuss the signs symptoms. They're also assessed on their bleeding side, so they use the as bled score, which has limitation as patient population, but we don't have a good risk stratification score for patients, but at least it's highlighting potential risk factors for bleeding. And if the risk-benefit ratio is favorable, then they have a discussion about initiation of pharmacological thromboprophylaxis for these high-risk patients.
You know, as you talk about those examples, I've been really impressed. I'm thinking in particular about the Vermont experience. And when they developed this multidisciplinary team, they were able to get their prophylaxis rates remarkably high. And I'm wondering if it's because of this idea of the teams coming together, right? The oncologist is obviously at the captain of the ship, so to speak, who knows all the elements of cancer treatment, but then they're being supported by the thrombosis expert, be it a hematologist or a vascular physician, but even more so being supported by the nurse and the pharmacist who really can spend additional time with patients talking about the importance of VTE prevention so that that burden's not being placed on the oncologists themselves. And I'm wondering, as you think about it, how important is that team-based approach to really implementing these guideline type recommendations?
Oh, I think it's essential. And as you mentioned, obviously the medical oncologist will be directing and making final decisions, but these patients will have different point of entry into the healthcare system. They'll be meeting different healthcare providers that may have more or less expertise on certain things and can provide healthcare advice and help to stratify patients. So pharmacists, for example, are a great addition to the healthcare team that can spend a bit more time and maybe probably have a bit more knowledge about the efficacy and safety of thromboprophylaxis and can help the oncologist make a decision about tailoring thromboprophylaxis in that setting.
Okay, so let's turn ourselves a bit. We talked about prevention of cancer-associated thrombosis being evidence-based, guideline recommended, but often underutilized. So, what happens now when we don't give chemoprophylaxis and then a patient does develop a thrombosis event in the setting of cancer? I certainly remember when I was going through training, the mantra was really low molecular weight heparin is much better for treating a cancer-associated thrombosis than a vitamin K antagonist. And I know there were a couple randomized trials really pointing us in that direction. I'm wondering, as you think back over the past decade or so, was that evidence always followed, or was there still a lot of VKA use in the cancer-associated thrombosis space? And what did that mean for patient outcomes?
You're quite right. And you're right that 5, 6 randomized control trial comparing low molecular weight heparin to vitamin K antagonist showed benefit, no difference in major bleeding. So clinical practice guidelines recommended it. But in real life, that was not always the case because, well, low molecular weight heparin is parenteral. It's a daily needle. It's an additional thing for patients to do. It's associated with lower compliance, less adherence, less persistence of the anticoagulation over time. And people would favor something that is more oral. And then vitamin K antagonists had all sorts of drug to drug and drug to food. It's terrible to manage warfarin in the setting of cancer because people have, sometimes they have nausea, vomiting, diarrhea. They have all sorts of medication. The time in therapeutic range in these trials is like 45, 47%. But people still favored this because it was an oral medication and it was cheaper than low molecular weight heparin. So despite the clinical practice guidelines recommending low molecular weight heparin, parenteral agent, but stable pharmacokinetic and kinetic that makes sense to use, a lot of people were still on warfarin.
So in the last several years, we've had sort of the emergence of some randomized trial data telling us that we can use the direct oral anticoagulants also for the treatment of cancer-associated thrombosis. And I'm wondering if you could give us just a very high-level summary of what those trials have told us as it sort of helps us think about, well, then what are we actually doing in the real world?
Yeah, so you're right. Since 2018, 6 randomized controlled trials have compared different direct oral anticoagulant to low molecular weight heparin. And overall, when you look at it, they've shown that direct oral anticoagulant seems to be associated with a lower risk of recurrence. So it seems to be more effective than low molecular weight heparin. But it's not as straightforward as the comparison between low molecular weight heparin and warfarin. Because remember, that would show that low molecular weight heparin was more effective, no difference in bleeding. For the DOAC versus low molecular weight heparin, it's a little bit more complicated. So yes, DOAC seems to be associated with a low risk of recurrence, so more effective, but that comes at a small price of increased risk of bleeding. So there's a slight increased risk of major bleeding that was not statistically significant, but an increased risk of about 25%. But remember, not statistically significant, but there was an increased risk of about 50% of clinically relevant non-major bleeding, and that was statistically significant. So what's a clinically relevant non-major bleeding? It's a bleeding that for which you need to seek medical attention or have an intervention. So we usually use the major bleeding definition in clinical trials, and that would be fatal event, critical site, drop in your hemoglobin by 2 grams, or um, you need 2 units of packed red blood cells. But a lot of patients with cancer have all sorts of other bleedings that may not meet that definition. So if you have bladder cancer, you're coming to the emergency room with hematuria, you need total bladder irrigation, you need 1 unit of packed red blood cell. This is clinically significant, but didn't meet the major bleeding criteria. So over time, we've developed this clinically relevant non-major bleeding definition. So DOACs are more effective, but associated with a slightly higher risk of having clinically relevant non-major bleeding, which is about a 5% absolute difference.
So as we think about the clinical trials, I remember looking at several of those when they first came out and saying, okay, this is going to be sort of my go-to strategy. I'm going to start by thinking about using a direct oral anticoagulant, but there are certain patients in whom I might have more caution or more concern. And I'm thinking in particular, those patients who have a GI luminal cancer, right? Something, especially in that upper GI tract. And I'm wondering, in the real world data where we have sort of a broader population, have we seen evidence of bleeding risk with the DOACs in those patients? And is that something we still need to be concerned about, or was that just a fluke of the trial? How should we as clinicians think about it?
Yeah, you're quite right that the first 2 trials comparing edoxaban and rivaroxaban to low weight heparin showed an increased risk of major bleeding. And that was mostly, when you looked at post-hoc analysis, it was mostly patients with gastrointestinal type of tumors, and then some of them had genitourinary type of tumors. So people were saying, well, maybe we should adjust. This was not necessarily seen in other trials. So Caravaggio comparing apixaban to low weight heparin, for example, they specifically looked at major gastrointestinal type of bleeding and didn't see any difference between apixaban or low weight heparin. And Canvas and Castadiva and other trials afterwards have shown that it seems to be similar. But when you look at the observational studies or the real world evidence, when these particular patients, so those with unresected gastrointestinal or genitourinary type of tumors, are not excluded from the analysis, it seems to be leading with a higher risk of bleeding complications. So a lot of the observational studies that we're looking at often exclude these high risk patients just to make sure that they're not incorporated into the argument. So right now, I think clinical practice guidelines, but also guidance from different societies are saying, DOAC should be the first line for cancer-associated thrombosis, but be mindful if you have a high-risk tumor type, maybe using an alternative for a while to challenge these patients to anticoagulation may be desirable.
Now, I know that our guidelines and the randomized trials use sort of the standard treatment doses of these direct oral anticoagulants when we're treating somebody who has an acute pulmonary embolism or an acute DVT. But I also recognize that in a patient with cancer, they're often receiving chemotherapy, and so they have several bleeding risk factors ongoing. One in particular is the issue of thrombocytopenia. And I'm wondering, how do you think about treating somebody who has an acute DVT or PE when you have thrombocytopenia? And do we have any real world evidence to help us make those decisions?
Yeah, so we do have a little bit of real world evidence because, as you mentioned, these patients with high risk of bleeding, so prior history of bleeding, high risk type of GI lesions, thrombocytopenia, patients with liver, renal impairment, were excluded from clinical trials. But you and I have to make decisions on a daily basis about anticoagulation. So you're quite right that this is often the first thing I consider. So I will say, is my patient at high risk of bleeding? Does he or she has any of these features. And if so, if that individual has any of these features, then I tend to challenge a patient to low microweight heparin, because we know it's been associated with a lower risk of having maybe bleeding complication, slightly shorter half-life, enoxaparin 6 hours compared to 10 to 12, depending on the DOAC you're using. And then if they're doing well with low microweight heparin while they're in hospital, for example, then I would discharge them home on a directal anticoagulant. And sometimes, because they may be in hospital for a while, that will also avoid the higher dose period. So for apixaban, you need to use 10 milligrams POBID for 7 days, which is a higher dose. Probably okay for most patients, but in patients with a high risk of bleeding, then sometimes I'm mindful of that. And then same thing for rivaroxaban, for example. And for edoxaban, you need to have 5 days of low microweight heparin anyway before you start edoxaban in that setting. So that's probably, you're quite right, that's probably the first thing I use. And then from a thrombocytopenia perspective, there's a little bit of data and a recent systematic review that showed that there's no right or wrong answer. But if the risk of having complications from a clot will decrease over time. So the highest risk period is probably the first month. So after an index PE, the first month is high risk of recurrence and bleeding. So if you have thrombocytopenia and then you're worried that the patient may have a recurrent event if you stop anticoagulation a week or 10 days afterwards, then maybe continuing anticoagulation with platelet support may be something to consider. The alternative to that is to tailor the dose of anticoagulation according to that. We don't really do that with DOAC so much, but we can do it with low microweight heparin. So some people may argue, well, if it's over 50, if the platelet count is over 50, then you can give therapeutic dosing of anticoagulation. If it's between 20 and 50, then intermediate dosing is okay. And less than 20, then you may have to just hold the anticoagulation at some point. So there's really two ways to manage thrombocytopenia in that setting. And then there's a recent observational study coming from the venous group in the United States that showed that maybe the dose tailoring may be superior, but in that particular group, they also had lower risk of clots, mostly line upper extremity DVTs. So right now the jury is out and there's a randomized controlled trial comparing. So I think for the time being, guidance would say, if you're worried about recurrence, try to continue therapeutic dose of anticoagulation if you can with platelet support. In patients at low risk of recurrence during the first month, then dose decrease or titration of the dose based on platelet count may be desirable.
Yeah, that seems like a really practical approach based on the limited real-world evidence we have, and we'll look for that randomized trial data to further guide us in the future. You talked about an important piece that I often get asked about, which is the timeline or the duration of treatment. And so we know that patients with cancer-associated thrombosis, we're often shooting for that 6 month of treatment with their primary anticoagulant. And I'm wondering, do we have any data to tell us if 6 months is sufficient and we should just stop? Or do we continue beyond that? How do you start to think about the duration and maybe the intensity of anticoagulation for a patient who has a known cancer-associated thrombotic event?
Yeah, so the good thing when we think about secondary prevention, so beyond 6 months to prevent the recurrence, the initial clot is cured, we're just going to do secondary prevention. The good thing is you can do probably anything because there's data supporting of all the different management options. But if you read the guidance, they would say if the cancer is still present, if there's still ongoing treatment for cancer, you should probably continue because the risk of recurrence or that risk factor is still present. Is if you discontinue anticoagulation, you may be at high risk of having recurrent event. Now, there's 6 pieces of information that are available, and they're looking at low microweight heparin and DOAC at both therapeutic and prophylactic dosing. So there's 2 single-arm cohort studies of low microweight heparin at therapeutic dosing. There's no controls, but if you compare the second 6 months to the first 6 months, the risk of recurrent remains low on patients that receive the intervention without increased risk of bleeding. So indirect evidence saying it's probably okay. If you look at Okusai VT cancer that compared edoxaban to low microweight heparin, remember this was a follow-up of 12 months. And if you look at the second 6 months, you have the same indirect evidence saying that continuing edoxaban at therapeutic dosing seems to be safe and effective in that patient population. Now, there's cohort studies or real-world evidence coming from Norway, where they stratified patient after 6 months, decreased everyone to 2.5 milligrams of apixaban and followed them over time, and that had pretty good rate of recurrence and bleeding. So that seems to be a reasonable option. And then there's a low molecular weight heparin at prophylactic pilot study that showed similar findings. Now, from a randomized controlled trial, recently the EVE trial from the US, the Mayo network, randomized patients at 6 months to 2.5 versus 5 of apixaban and followed them over time. And this was a trial looking specifically at major bleeding, and it was a superiority trial, but if you look at the point estimate, it was reasonably low for both groups, and the risk of bleeding was also very reasonable. So meaning that it's probably similar using 2.5 versus 5 of apixaban. Now, there's a large European-driven randomized control trial of over 1,000 patients, randomizing patients to apixaban 5 or 2.5. So we finished enrollment. They will open up the database in September, so we'll soon have data for that setting. But for the time being, what I do is I just assess the risk of clotting and the risk of bleeding, and I make a treatment decision based on that, which is very similar to the decision I made when starting treatment, for example, except for dosing, of course.
Yeah, no, that all makes a lot of sense. And as you mentioned, it gives us as clinicians to really personalize that treatment choice to the individual patient, which is wonderful. Well, this has been such a comprehensive review of real-world evidence in the prevention and treatment of cancer-associated thrombosis. You know, a couple key takeaways that I'm thinking of is, first, we know that we should be giving chemoprophylaxis to patients who are at risk for cancer-associated thrombosis, but we're just not doing it. And so the systems that have done it well have made this something that's built into their routine practice. They've brought multidisciplinary teams together, and they're achieving very high rates of chemoprophylaxis in at-risk patients. From a treatment standpoint, we talked a lot about how the guidelines and the evidence tell us that we should be treating now probably with a direct oral anticoagulant first line, followed by a low molecular weight heparin. But of course, there are certain populations in which we may be concerned, and the real world evidence supports that certain patients, such as those with gastrointestinal tumors, may be at higher risk of bleeding. So starting more with the parenteral agent is probably a good place to go. And of course, as we think about the duration of treatment, as you just highlighted, you know, we got to get through that first 6 months if the patient can safely tolerate it. And then after that, we sort of personalize based on their risk of thrombosis and bleeding. Anything else that you would add as a key take-home point here?
No, it was a fantastic summary, Jeff. Thank you very much for having me.
Well, I really appreciate it. This has been a wonderful conversation, and thank you all for joining us. We hope to see you again on another one of our Think Thrombosis podcasts from medauthority.com.